We go to Tina. So Sean, if you could please introduce yourself.
Bonjour, my name is Sean Middleton. I do cultural and spiritual care here at NACC. I also have an MSW with a clinical focus, and I'll be doing a lot of work in the schools and hopefully doing some counseling groups, parenting groups, men groups, kind of with a cultural and spiritual focus at the Native American Community Clinic.
Very good, thank you. And then I'm going to introduce the team here. Michelle, could you introduce yourself, please?
Hi, everybody. I'm Michelle Corcoran, the nurse manager for the MAT/MOUD program here at NACC.
Hey, Nikki.
Hi, I'm Nikki Jordina. I'm the infectious disease nurse at NACC.
I'm Tina. I am the harm reduction supervisor here at NACC.
Lindsay.
Hi, I'm Lindsay King Cooney. I'm the community and tribal engagement specialist here at NACC.
And I'm Kari Ravi. I'm in family practice and addiction medicine physician at NACC, working with the MAT program. Dr. Reznikoff, would you mind introducing yourself, if you're able to?
Can you hear me?
Yes.
Yeah.
Oh, great. Okay, I am Charlie Reznikoff. I'm an addiction medicine and internal medicine doctor at Hennepin Healthcare. I'm glad to be here. Thank you.
Thank you so much for coming. So we're gonna go ahead and go through our agenda. So we already did the blessing, and now, of course, I'm going through the agenda. We're gonna do Zoom guidelines. And then Tina's gonna do the announcements for us. Dr. Reznikoff is presenting our didactic today, and again, thank you for that. If we have time, we have a case presentation. We do not have a case presentation today, and then Tina will close us. Okay, I'm sorry, we're changing things up and I lost track of myself. So yes, so as far as Zoom guidelines, please let us know who you are. You can introduce yourself in the chat function, your name, title, organization, and email. As we all probably know by now, you can right click on your image and rename yourself so that your correct name shows up on your screen. If we are hearing a lot of noise coming from you, we might mute you. So if you're able to mute yourself when you're not speaking, that's helpful, because you know our phones a lot of time make more noise than we expect them to. Thank you. And then again, please don't be offended if we mute you. It's just so that everybody can hear. You can use the chat or hand raise function for attention, and please don't use any protected health information with us. And Tina, if you can do the announcement.
So the next echo is October 5th. And Dr. Ravi will be talking about MOUD and pregnancy. After that, on October 19th, Melody Nadeau from University of North Dakota will be speaking on centering culture in the treatment of OUD in American Indian and Alaska Native communities. Just a reminder that there are a bunch of other echoes related to harm reduction, infectious disease, and other topics. So if you need links or more info, I know where to find them and can provide those to you. Case presentations. I think everyone here probably knows what a case presentation is. So they're real life clinical scenarios that have presented challenging or complex questions within our practice. Anyone is welcome to bring a case presentation. If you'd like to do so, please let me know. And for this session, eligible people can receive continuing education credits. You'll just have to complete the survey that we send out after the session, so look out for that. And I'm going to stop sharing and hand it over to Dr. Reznikoff.
Okay. So now I will start sharing, and I am speaking through my phone, but sharing on my computer. I hope that doesn't cause any glitches, but let's go with it. The other thing I will say is I've had quite a day with a lot of things happen right before this talk, so I'm a little frazzled. And so I really appreciated the words about taking care of yourself that started this, because that was helped me in this very moment. So I appreciate that. I have been thinking of, so I've been in addiction medicine for 15 years. And I love it. And I love it as much today as I've loved it on the first day, maybe more. And what I don't love about addiction medicine is how busy it is, how frantic it can be, how, maybe there's not enough of us doing our work. We wish we had more of us doing our work because it feels like, never is there enough. You could always just there's always more work to do. And that can be frustrating or make you sad or tired or hopeless. But one thing that has not been a problem, for me at least, is the patients. And I say that knowing that it is not easy always, that not every patient is ready, and that some patients are very challenging in lots of different ways. But if anything, the patients have kept me energized and wanting to stay in this work, whereas all the other BS, all the other red tape and everything else that we have to deal with is the thing that makes me tired. And so I was just thinking about that, and I was thinking about why. Like, what is it that many people have a hard time talking to individuals with addictions? They, maybe have judgment about them, or they don't feel comfortable around them. And I was thinking about why is it that 15 years later, this is still one of the best parts of my day. And I have a couple thoughts about it. And so I'm going to share those thoughts, and then we can go to the talk. Number one, you may have heard about the difference between cognitive empathy and emotional empathy. And this is like a weird thing about me. I'll share it, but it may not be true of everyone. I have a lot of cognitive empathy. In other words, I'm always thinking about what's going on with you and how I can help you. But I actually don't get dragged into emotional empathy, where I'm feeling what you're feeling. So that's kind of odd about me, but I'm always thinking about the patient, how they got to this spot, how I can help them, what they're experiencing, but I'm not letting it affect my personal emotions. And I think that's just something I practiced over time, that I'm always thinking about them and caring about them, but not feeling what they're feeling, because many of the patients we work with are very traumatized and they're suffering. And if you feel what they're feeling, you're going to suffer too. And if you suffer that much every day with them, you may not last. So to care a lot about them, but to not feel everything they're feeling. And that makes me maybe it makes me dispassionate. I don't know if that's a good thing about me, but it has helped me sustain year after year after year. Think about them, but don't feel all their trauma personally, because it's too much in a day. And you may have different ways of approaching that. I'd love to hear your own approach to that. Anyways, the other thing that I was thinking about that's helped me survive 15 years is, if someone is intoxicated, I usually know pretty quickly, and I change my plan. I'm not going to have a heart-to-heart with someone who's intoxicated. I'm going to try to make sure that they're safe. I'm going to try to keep them safe. I'm going to try to make sure what do they want? Try to help them a little bit. And we'll save the heart-to-heart for when they're ready. And, but I think a lot of people get frustrated and burned out when they try to have a meaningful conversation with someone who's intoxicated. And so part of this talk is about that, is how do you know when someone's intoxicated? So you can sort of pick your battles. You can pick your moments, I should say, and say, this isn't the moment to have that heart-to-heart, because they're dealing with an intoxication in this moment. So how can I serve them in this moment for what they need, and pick another moment to talk about, what I hope for them. And just, for today, I'm just going to try to keep them safe and take care of their needs. Okay, that's a rambly introduction. If anybody else here has an approach to dealing with all the trauma and suffering of your patients, I said, try not to feel it personally, but do think about it and engage on that level mentally, but not emotionally. If someone else has advice on how to manage that, because we deal with really suffering patients, traumatized patients, and how can you do that day in and day out and sustain? So anyways, let me see. Oh, Sean, please share.
I've been doing this work for 35 plus years, and I think you're dead on. And one of the ways I was taught to look at it is it's the same kind of thing, but it's hard not to carry those burdens. But the way I was taught is when you come to talk to somebody, I worked with, back in the day, we call them our Skid Row drunks, right? We don't use that language anymore, but I'd be out on the streets doing that kind of work. And the thing that we would always say, we were taught by our elders is, we're trauma-based in my family and in my organizations I've been with. And so we would just say, oh my God, I'm so happy you survived today. And that opiate, that drink, whatever you're using, that's the only tool you have right now. And I'm thankful for that tool because it's kept you alive to this point. And when you're ready, we have other tools and you can come and partake in them. But it's the same thing. So when you're ready and you want something else, when you want to start living instead of surviving, come talk to us. And by doing that, communicating that took a lot of that weight off of us.
Yeah.
And so that's kind of how we'd approach it. Same kind of thing, but it's like, I love that you're surviving and I can celebrate that today. I love that you're here, but we need you to be, we can't do that kind of conversation with you until you start living. And when you're ready to do that, even if it's sporadic, we'll welcome you. And that literally took a lot of the weight of that burden off of us because we could celebrate the fact that they were living, even if they were, wasted. Okay? So just my thoughts. So
that's great. Thank you. Okay, so I'm going to just go through some different types of intoxications and how you'll identify them, and then how that can help you sort of change your plan for that visit. And then maybe to think about your own discomfort with talking to someone who's intoxicated, understanding the limit of what you can do. Okay, so I can't help this. I do this automatically when I enter a room in 10 seconds. Now, I have an idea, and I'm not perfect. I make a lot of mistakes, but I have an idea of what drug this person might be on. And I see it right away. And the first thing I look at is their pupils. And I'll give you lots of examples of this, but pupils are very telling of someone's, what drugs they're on. And then I look at their eyelids, and then I kind of listen to their speech. Are they speaking fast or slow, slurred speech? And also, what are they talking about? I listen to that. I look at their hands and how their hands are moving. And I look at their feet, and I look at their body and how their body is moving. I notice their skin, and I notice if I've known them before, have they lost weight or maybe gained weight? And all of those things collectively, pretty quickly, I have an idea about what drug they might be on. Again, I'm not perfect, but it has helped me a lot. It has saved me a lot, and it just comes from practice. I now, when I'm out there in the community, I will notice anyone. If they're on opioids, I might notice that they're on opioids. Not perfect. And I think one other tip is if someone might be impaired, we have a tendency to push our agenda on them, maybe especially doctors. but, I'm in a rush. I got my checklist of things I want to do. So I'm going to force, I'm going to try to get you to do my checklist, my agenda. That's a very typical doctor thing to do. But when someone comes in, it's hard for us, it's hard for me but it's important to sometimes just be quiet and listen and observe. And you'll learn a lot about them, including what drug they might be intoxicated on, if they are intoxicated, just by quietly listening and observing. Especially me and especially doctors, the tendency to talk too much, talk too early, to take over the conversation really affects your ability to notice them and to appreciate them for what they need. I have videos, but for the purposes of time, you can look at these videos later. I might show one just for fun. So again, like I look at everybody's pupils now, and the person on opioids is this small pupils, right? So small pupils really suggests opioids, and bigger pupils, like in picture B, would be pretty normal pupils. Maybe they're not on any drugs at all. Again, there's a photo of small pupils, very small, and you can see that the eyelid is kind of drooping into the pupil as well, which is another clue. And then, many of my patients have dark skin, and many people with dark skin also have dark eyes. Not always, but it can be really challenging sometimes to see people's pupils if they have dark colored eyes. Actually, you don't need to have dark skin to have dark eyes. That's obviously silly, but this person does. So very dark eyes, and so sometimes they'll catch me squinting at them, and they're like, "What are you looking at?" And I'll say, "I'm just checking out your pupils. I'm sorry." Some people come in with sunglasses on, and they're a little, because they know, because they know that if you look at their eyes, you can tell what they're intoxicated on. So I'll sometimes ask them to take off their sunglasses if they're comfortable with that. So very few things cause small pupils. Basically, someone looking directly into bright sunlight will have small pupils. It could almost look like pinpoint pupils if they're really getting direct sunlight in their face. But besides sunlight, the medication clonidine does cause smaller pupils, but mainly it's just opioids. Someone with pinpoint pupils, small pupils, are probably on opioids. In addition to having small pupils, they're going to have heavy eyelids. Usually both of their eyelids are going to be drooping down low. Their speech is slow and deliberate. Their movement is slow and deliberate. And they have a tendency to drift off to sleep. And then they wake back up and finish their sentence. And you've seen this before. This is called nodding off. Generally, their people are calm. They're not argumentative. They're not rambling. They may slur their speech, but that's not really the obvious thing. They're just really look like they're right on the verge of sleep. And they're slow. They're drifting in and out of sleep. They're mildly defensive, if defensive at all. They're pretty calm. They're not a danger. People on opioids are not a danger. Recently, we had a patient who was in the hospital, who had already left the hospital against advice once, and she was very estranged from the employees of the hospital. She did not like being in the hospital. She wanted her boyfriend in the room with her. Well, her boyfriend looked intoxicated on opioids, and the nurses were very worried. And I said, "What are you worried? I don't know what you're worried about. You're maybe worried on his behalf, but don't be worried about your own safety. This is not a dangerous person. Someone intoxicated on opioids, they're too high to be dangerous on opioids." So again, if you look at, in retrospect, knowing that Prince had opioid use, probably opioid addiction, you look back at some of these photos of Prince and you say, boy, small pupils, right? Those are small pupils. And Prince wore sunglasses a lot. Carrie Fisher, who played Princess Leia, also died of opioid overdose. You look at her photos, little hard to see. Those are small pupils, right? Tom Petty also died of an opioid overdose. But you look at his pupils, and whenever this photo was taken, he was not on opioids at this time. So those are normal pupils, even though I'm just comparing his pupils to these other sort of celebrities known to have opioid use disorder. And then here's an example of someone whose both eyelids are covering his pupil. Now that can happen with old age, probably true of this individual, just as the skin gets a little bit more saggy with old age. That can just happen with some people. This person has a lot of skin around his eyes. It's probably not opioid related. But if you saw a young person and both pupils were obstructed by the eyelids, hold on, sorry, this was getting called. So then you would think, oh, maybe they're on opioids. Whereas if both eyelids are over the iris, the colored part of the eyes, that person is not on opioids. I mean, well, it's less likely that they're on opioids. Usually, if you can see fully around the pupil, both pupils, they're not on opioids usually. So this is, again, dark eyes. And I just got this photo from the internet. Dark eyes, but you can see, if you looked closely, you could see small pupils for each eyes and a heavy eyelid, a lagging eyelid around each eyes. Also crusting on his lips, and he looks just sort of fatigued, like he might fall asleep. Another thing I always notice, this area right here, the left brow, someone might have hit him, honestly. Where they have bruises on their face or scratches on their face does tell you something. Because most people are right-handed, so that area does sort of suggest someone, you don't know, but somebody might have hit him, unfortunately. So these folks are not inappropriate, they're not random, they're not rude, they don't ramble, they drift off to sleep. They might say something like, oh, I didn't sleep well last night, or oh, my anxiety medicine's making me tired. They might complain about pain, but then they'll turn around and fall right asleep. They're pretty non-threatening. The main risk to them is they're overdosing. So they might need Narcan. Okay. So you all probably are experts in that. You've probably seen that a lot. If you're around someone, they're nodding off, the most important thing is probably to check their oxygen level. Keep an eye on them. Make sure if they leave with someone safe who has Narcan. That's what I would do. We would usually ask them to stay for an hour. If they insisted on leaving, we might call them, make sure they have Narcan, make sure they're going somewhere so they're not alone, and give them a call.
Dr. Reznikoff,
Yeah,
there was a question in the chat.
please.
Christine Matson asked, what is the effect of buprenorphine or high dose buprenorphine on the pupil size?
Oh, yeah. So this is great. So buprenorphine is right in the middle. Chris, awesome to hear your question, and I'm glad to, it's always good to interact with Dr. Matson, whom I've known for more than a decade. Yeah, I mean, I think Dr. Matson, I would, you could share your clinical observations as well. Many people on buprenorphine, even pretty high dose buprenorphine, have relatively normal pupils. They can pass. Some people are a little more sensitive and have slight pupil constriction. So buprenorphine, but I think the important thing with buprenorphine is that we get to know these patients over and over and over again. We see them every month or every other month for years and years and years. And because of that, and because I always check their pupils, I get to know I know a few patients that have constricted pupils from buprenorphine, and everything else seems like they're doing great. I don't worry about it. But I also know a lot of patients whose pupils I expect to be normal sized, and then one day they come in and their pupils are much more constricted than I'm used to. So then I worry about it. So I in general, most people can pass on buprenorphine as not being on opioids. Some are a little more sensitive to it and have constricted pupils. And the most important thing is, as you get to know someone, you know how they look when they're sober, so you can detect that their pupils are smaller than normal. Chris, great to hear from you. That's awesome. On to big pupils. That's probably a dilated pupil from an ophthalmological procedure, but I just wanted to bring up big pupils. Many things cause big pupils. Stimulants, methamphetamines, cocaine, empathogens like ecstasy, hallucinogens like LSD or mescaline or whatever. All of these drugs actually, the first three work similarly, and they all create big pupils. Opioid withdrawal creates big pupils. Ketamine and PCP can give you big pupils. Sedatives like benzos, Valium, Xanax, Ativan, they give you big pupils. And anticholinergics like Benadryl or hydroxyzine or some one of those medications also give you big pupils. Lots of drugs give you big pupils. So I think, first of all, if you have really big pupils and you're sedated, I think benzos or maybe anticholinergics like Benadryl or hydroxyzine. So if you have big pupils and you're sedated, that puts you into this only one of those two. If you have big pupils and you're activated, you're energetic, you have high blood pressure, you're tachycardic, you're probably going to be one of these stimulants, hallucinogens, opioid withdrawal, or PCP intoxication, ketamine intoxication. They're PCP and ketamine, they're not always activated. They can be mellow or activated. If you've never seen someone violently intoxicated on PCP or ketamine, that's okay. You're lucky. But so that PCP is kind of right, and it's a little bit of a confusing one. So maybe don't dwell on that. But with PCP, you get nystagmus, meaning shaking of the eyes or spinning of the eyes. So that nystagmus is typical of PCP or ketamine. So that's kind of what sets it apart. Opioid withdrawal, this is simplification. A lot of them will have abdominal pain, nausea, maybe diarrhea. So if you have big pupils, you're restless, you have abdominal pain and diarrhea, that's probably going to be opioid withdrawal. And finally, if you have big pupils, you're activated, you're energetic, but you don't have pain, you don't have abdominal pain, you're not having diarrhea, you don't have spinning, rotating, or jiggling eyes, I would worry about stimulants, methamphetamines these days. So again, I think the top picture has somewhat large pupils, but the bottom picture, she's got big pupils. She's on something. So again, like, is she sedated? I'm thinking benzos. Is she wired and activated? I'm thinking stimulants. Is she got upset stomach, diarrhea? I'm thinking opioid withdrawal. And if she's got sort of jiggling eyes, I'm thinking this PCP. That would be a rarer thing, but we do see PCP still. Again, this person probably has large pupils. You can see from the bright reflection in her eyes, she's looking straight at a light. Normally, if you're looking straight at a light, the pupils are going to be smaller. So the fact that she's staring into a light with pupils that size do suggest she may be on a benzo or a stimulant or something causing her eyes to be larger. So let's go through some of these other clues you'll see about benzos. I'll tell you, benzos is one. I can't. Experienced drug counselors will go into a room and just lose 30 minutes of their life. The futile, circular conversation that just keeps going and going and going and never goes anywhere with someone intoxicated on Xanax. And it's not helping them, and it's not helping you, because they're blacking out and you're not making progress. So it's really important to identify when you're in the room with someone intoxicated on Xanax and change your plan, change your approach, or you're going to come out kind of frustrated. You're going to come out of that room frustrated. Their speech can be slowed, but more importantly, it's slurred. They're clumsy. They have clumsy mouths, so they can't pronounce words, and they have clumsy bodies, so they can't execute actions. So you'll have slurred speech. You'll have unsteady. They may walk as they enter the room. They may bump into the door frame. They may try to put their arm, put their head in their hand and put their elbow on the table, and their elbow might miss the table and slip off the table. Sometimes just the act of looking for something in their purse seems like it's the most complicated thing they've done all day. They just cannot navigate the contents of their purse. And then in 30 seconds, they forgot what they were even looking for. So they're clumsy. And you'll hear that in how they speak, you know, kind of a thick tongue, a clumsy tongue. You'll hear that in how you'll see that in how they move. In addition to being physically clumsy, they have a tendency to ramble and be tangential. They'll go from one topic to the next topic to the next topic, and then they'll kind of forget what they're even talking about and why, how they even got there. They'll just, this is if you just quiet and let them talk for a few minutes, they'll just talk and talk and talk from one thing to the next, and it all kind of just rambles. And in that, they may take you on a little bit of an emotional roller coaster. They may be, first they may act like they're angry at you, but pretty quick they forgot they're angry at you, and then they're giggling. And then pretty quick they may even flirt with you, which would be inappropriate, but they may flirt with you. And then they may act really sad about something and even start crying, and then they may get angry again. And they seem to sort of loosely travel from emotion to emotion to emotion on this emotional roller coaster from topic to topic to topic. They do get angry, but they don't stick with anger. They have a tendency to just move on to the next emotion. They do have poor judgment, so they may say something inappropriate. We often have people who come in and make a threat. They're impulsive, they're intoxicated on benzos. Who knows if they even mean it? This stuff they just sort of say it. And then in 5 seconds, they forgot they said it, they move on to the next thing. Well, if you're a addiction counselor or a nurse or someone and you feel like you've been threatened, it's very easy to overreact to that threat. So I've had a few threats in my life coming from people. I have a voicemail, and I've had a few instances where individuals have gotten really intoxicated on benzos and have called and have left a rambling message for me on my voicemail. I just ramble on and on and on. And in that rambling, they say things that are very inappropriate or even threatening towards me. I always interpret that in light of that they're intoxicated, they're impulsive, they're disinhibited. Rarely is that a substantial threat, but then I need to decide how I manage that threat. Usually in the context of it, benzo intoxication, I don't overreact. I talk to them when they're sober. And then we talk it out when they're sober. And there have been times where I've literally played back the recording of what they said, and they were very embarrassed and surprised to hear their own voice saying those things. But I know it can be really challenging to have people say inappropriate things, but that you might experience that with benzo intoxication.
Dr. Reznikoff, did you see
yeah.
there's Alana put a question in the chat?
Great. Thank you for moderating the chat, by the way.
Yeah,
Thank
of
you.
course.
Go for it.
Can I read it?
Yeah.
I feel like this would be hard to differentiate with a mental health diagnosis. Is pupil size a good way to tell the difference?
Yeah, a couple of these things are going to be tough to differentiate for mental health diagnosis. Stimulant intoxication and manic bipolar disorder is very tough sometimes to differentiate, and sometimes it's very tough. Yes, pupil size is a clue, and the slurred speech and coordination issues is another clue. Both of those are good clues. This is, I don't mean to say this facetiously, but if you call, I sometimes will say, if you listen to the Vikings phone-in radio show after the game, you will hear people calling in intoxicated on alcohol. And if you just listen to how they construct a sentence, how they try to pronounce words and they fumble, their words fumble in their mouth. And it gives you a sort of ear. It's like practicing for our patients. And benzo use can sound a little like alcohol intoxication with the slurred speech and the sort of rambling and the sort of they're trying not to slur their speech. They're trying to hold it in, but they can't quite manage it. And the sort of inappropriate comments. And so every week for the next 3 months, if you wish, you can hear examples of this type of intoxication on the radio after whenever the Vikings play, because unfortunately people call in intoxicated on the radio. So that, again, that's a bit of an it's a bit of a facetious remark, but I do think you can differentiate it from a mental health disorder, from the slurred speech, from the excessive clumsiness and the big pupils. But some of the emotional lability could be true for borderline personality disorder. And if you give someone not with borderline personality disorder benzos, it's like amplified. It's like, it's really extreme in that case. So that's a good question. Remember, these folks are often blacking out. They don't remember what they're saying. They don't remember what you're saying. They're unsafe to drive, but more importantly, not everybody has a car. They're unsafe out there in the public because they could be victimized. And they do get victimized, because if I can recognize they're intoxicated on benzos, there are certain individuals out there who can also recognize it and might steal their money, steal their medications, or worse. And so these folks, when they're really intoxicated on a benzo, they need help getting home safely, or they need help, they need to be around a friend. So I try to, and it will feel rude when they're rambling on and on. It will feel rude to interrupt them. But if you never interrupt them, you might be caught in that room for 30 minutes. So you need to find a diplomatic way to stop them from talking, to redirect them, to focus them, and to try to get them to wherever they need to go safely, hopefully with someone to look after them, because these folks do get taken advantage of in the community, because they don't have a good memory and they can be lured into dangerous situations. I'm just going to keep moving. Opioid withdrawal. Opioid withdrawal. I don't know about you all, but I actually don't see full opioid withdrawal very often, because usually it's so awful that people don't let themselves go there. But if when I do see it, they're very distressed. Full opioid withdrawal, they are very distressed. They're very uncomfortable. They probably maybe vomiting or diarrhea. They're sweaty. Their vital signs are abnormal, and it is not a secret what is going on. They will tell you what is going on and what they need. More likely, you won't see it because they're going to leave. They're going to get up and walk out and go look for opioids. What you're more likely to see is early withdrawal, where they're very anxious, but they're not yet that sick. And so here's the timeline. Typically, although everything's slightly different with the fentanyl era, within 12 hours from the last use, they're already craving, uncomfortable, anxious, but maybe not in physical withdrawal. By 24 hours, they're going to be in physical withdrawal. That's when you're going to see big pupils. That's when they're going to have diarrhea 24 hours after their last use, usually. And then for the next couple days, they'll be hurt. I mean, if they stay in withdrawal, they're going to be really hurt, or they're going to go seek opioids. And it might take 5 to 7 days for resolution of acute withdrawal. But then for 6 months, they may have sort of this chronic post-acute withdrawal. So within 12 hours, you're going to see them at 12 hours. They're anxious, they're desperate. They know what's coming. The storm is coming. They may be demanding of opioids. They may be anxious. They may be impatient. If they figure out you can't help them, they're going to walk out pretty quick because the clock is ticking. And by 24 hours, the storm has hit and they're hurting. And most people don't even let themselves get 24 hours. They go find an opioid. But occasionally, you're going to see it, especially maybe if you administer Narcan, you might see them because they're suddenly this sick. If they're on Suboxone, buprenorphine, naloxone, that timeline is much delayed, but it still happens. So instead of 12 hours, it might take 36 hours for them to start craving and having anxiety. Normally, everybody's different, etc. It's the same process, but it just takes longer. So buprenorphine is nice because it gives people more time to call their doctor or nurse practitioner and get a refill. If you are a buprenorphine provider, I would just give you this little piece of advice. A big problem with chronic pain treatment and opioid use disorder treatment is that even if patients run out of their medicine just a little bit. So yesterday I had a patient call me and This guy is the nicest guy. He's a total sweetheart. But he called me and said, I ran out early. Can I get a refill? And when I called him, I tried to just talk to him normally. But man, was he argumentative. He was just a jerk to me. I mean, I was probably a jerk to him too, but he was really rude to me. He was argumentative. He's never interrupted me. He interrupted me. He was demanding. He was sort of like, okay, well, forget you, kind of, he was in withdrawal. And I just hadn't interacted with him like that ever. And so what happens sometimes is patients come in to see you when they're out of their meds and they need more meds and they're in withdrawal and they're irritable. And so sometimes you only see these, if they're not at the right dose or if they're overusing their dose, every time they come to see you, they're in early withdrawal, they're irritable, they're cranky, and you might think this person's kind of a jerk. But then if you get them to a stable dose and they feel pretty good about where they're at, you might be really surprised. That wasn't them, their personality. That was just the fact that they kept running out of meds early. And then they were coming into you desperate in an irritable state. So over time, I've really think it's important to try to interview patients when they have not run out of their meds, because it's not going to be a happy interview. But if you interview them when they're on their meds at a stable, appropriate dose, it's just going to go much better. You're going to have a lot more of a meaningful interaction with them. So I'm very aware of that. If they've run out of their meds, if they're in withdrawal and they're cranky and irritable, pick your battles. The goal today is to get you back on your meds. Can I call you next week when you're feeling better? Then let's keep it simple. Let's get you back on your meds and let's not get into an argument right now, because neither of us are in a good spot right now. I'm upset that you ran out early and you're in withdrawal. This is not the time for a heart-to-heart. Let's let it. So that I made a mistake because I got in an argument with this guy. He was irritable. He was being a jerk, and I argued back. And afterwards, I was like, I just needed to get him back in his meds. Talk to him next week when he's feeling better, or even in a day when he's feeling better. So the final one I'll talk about is stimulants, and then maybe I'll do this quickly. Hopefully, be done early if there's more discussion or if there's a case. I'm sorry, I'm going long. This is how I roll.
Are you watching the time?
A little bit, yeah.
Okay, cool. I just want to make sure.
Yeah, I see it's 12:50. So I'll just quickly run through this, then we'll be done. Stimulants, big pupils, they're active, they're vigilant, they feel paranoid, they feel persecuted, they've kind of rapid speech, they may be kind of contorting their lips, contorting their fingers, tapping their feet. This is a person you need to be careful around. Of all the people, this is a person you need to be careful around. Because these folks under the influence of methamphetamines or cocaine, not all of them, but some of them can be aggressive. And so this is not a person that I spend extra time with. If I think you're intoxicated on stimulants, what do we need? What do you need today? And let me do whatever I can do to help you today. And then let's talk later. I'm not gonna, let's stay here and have a heart-to-heart. Hang out in the lobby of my clinic for a half an hour. No, that's not a good idea. Let's get you seen quickly. Let's address whatever requests you have, and let's get you out. Because right now you're on meth, and we don't want to have any extra time where you're hanging out in the lobby, where you're talking to all the nurses and doctors and counselors. Let's just get you taken care of and move you on your way. When you come back and you're in a better spot, then we can have more of a heart-to-heart. Of course, always think about sexually transmitted infections, HIV, syphilis, hepatitis C. Eventually, you got to get around to that. That's really, unfortunately, running rampant in this community. And I'll just underscore the point. The main person to be aware of and to be cautious around is the methamphetamine or cocaine intoxicated individual who's feeling paranoid, who's feeling persecuted, who's feeling a little argumentative and aggressive. De-escalate, make sure you ask them what they need, address what they need, and see them next week. And it'll be a lot better when they're calmed down. Besides that, I'm just de-escalating constantly and trying to quickly address their needs so that they can leave. Again, bottom line, everybody comes in, I look at their pupils, I look at their eyelids, I listen to their speech, I watch their body move. I think about what drugs maybe they used to use, and that helps me predict. And then I say, you know, this is the drug they're probably on, and based on that, I pick my battles today so that we can keep them safe today and we can have our heart to heart another day. I think I'm gonna stop there. All the rest of it is more on the same topic, but I think that we should have some time either to talk about a case or to discuss further. So I will send my slides and you can look at them. Please email me if you have any questions.
Thank you so much, Dr. Reznikoff. Does anybody have any questions about the presentation? About any parts of that Dr. Reznikoff went over?
I have a question. This is Laurel Meyer. Great presentation, by the way. I guess I was just curious, and this, Dr. Robbie, you can answer this too if you have some insights. But for that person who is going through the withdrawal, I feel like we do see that from time to time here. And I'm curious, how do you manage that? Like, what is your suggestions for handling that?
Well, I'll start, and then the other doc can chime in. If they're on buprenorphine, I try to facilitate getting them a refill now, and then we're going to have a more challenging conversation in a couple days about how did this happen. So what I would do is I would often write a prescription and schedule maybe a telephone visit in a couple days to have a more challenging conversation when everything's kind of calmed down. If they're not on buprenorphine or methadone now, I might offer it. And I think sometimes if you catch it when they're in withdrawal, it might be the best time to help them make a change. So I might offer it if they don't want it, or if you know, you don't have the capacity today to offer these things, buprenorphine or methadone. Then I think showing a lot of empathy and giving them any additional medications that can help them, and understanding that they're a risk if they're not given something else of going using opioids again. So maybe a naloxone kit would be good too. That's kind of my answer. Anybody else want to chime in?
Yeah, so I would agree with everything that Dr. Reznikoff said. I think, we see this a lot in our clinic as well, and it very much depends on where the patient's at and what the patient wants. So it's sort of kind of trying to make a quick assessment as what they need from us. So if they are looking for buprenorphine, then we try and move through that conversation very quickly. We don't do a full intake, for example. We try and assess their needs. We assess if they're on fentanyl. We assess the risk for precipitated withdrawal. We actually might give them a microinduction, and they might need to continue to use until they can get that going, for example. So we know that the storm is coming, as Dr. Reznikoff said, so we try to meet their needs as succinctly as we can and help them to get to their next solution. So again, we try to meet them where they're at. They need compromise, they need a microinduction. Can we give them buprenorphine today? And then and to help them to get through the clinic as quickly as they can, because if they're not interested in buprenorphine at all, that also means their patience for whatever we're doing for them is going to be very low. They're going to be trying to get out of the clinic, and so we also try to make sure we're meeting their needs quickly and getting them out. And additionally, as Dr. Reznikoff said, making sure they have Narcan, and if necessary, safer use supplies like syringes or other supplies. And also the thing we've learned is to not get them the supplies before we're done with them, so that they don't use in the clinic, and then we get them out of the clinic as soon as we give them those safer use supplies. Yeah.
This doesn't strike me as your all's approach, but some clinicians really want to do some patient contract, sign this contract before that's fine, but I really don't think that moment when they're in withdrawal is the right moment for a patient contract. you can mention it. You can mention some very simple expectations, but I think, still the methadone clinic still does these complex all day, first day intakes.
No.
And it really doesn't make sense that you, on your very first day, you're here for 5 hours. You're not going to remember all that. So we should really be reminding people over time as they enter treatment of all the expectations and issues and side effects and all the rest.
We find that the phrase medication first is a good approach, that we get a person stable and then have meet the long-term goals later. Now, Dr. Meyer, I know that you're not in a clinic where you're prescribing buprenorphine, so I think that they're gonna want to leave and use, or you might want to just connect them with a resource to help them with their withdrawal.
Any thoughts on what resource we would, I mean, I would probably think the clinic would be the
Yes.
first clinic. Well, that's where we usually send to if somebody's having troubles, but anything else you would recommend with that?
Just again, making sure they have Narcan, and maybe some education around safe use as far as injection and stuff goes. Again, it depends where the patient is going with that.
Emergency departments these days are so overrun and overcrowded. They're not very healthy places. They're not very healing places to go. But in the dream world of the future, emergency departments would be able to start to handle this better. I am hesitant to tell a patient to go to the emergency room now because there's such a long wait to even be seen, and sometimes they're very challenging interactions. But I do know my emergency providers would love to have the opportunity to start someone on buprenorphine if they weren't so darn busy and stressed out. So maybe someday.
Yeah, and Dr. Barry, you can always, just sort of as one, you can always call the clinic, and with somebody like that, we'll try and get them in right away.
Thank
Yeah.
you.
Michelle or one of our MAT team.
Yep, if somebody's in active withdrawal and wanting Suboxone, we try to get them in and out as quickly as possible.
We are about to hit 1 o'clock, but I did want to mention there was one more question in the chat, Dr. Matson. So if you send a stimulant intoxicated patient out of the clinic with buprenorphine script in hand and they hurt someone or in a motor vehicle accident 15 minutes after leaving the clinic, are you legally liable for letting them out of the hospital? I would assume same for ETOH intoxication.
Alcohol. Sorry.
Yeah, I mean, that's a good question. So, I mean, I will at times, occasionally, stimulant users are very focused on specific individuals who have wronged them or something like that. And they'll name a person. And other times, stimulant users are generally aggressive, but they're not specifically naming a person that they are angry at. I will sometimes assess whether they are a risk to someone else. I have had one person on cocaine name a doctor who was down the hall and say, I want to go assault that doctor. And I was worried enough that I actually broke confidentiality and informed the doctor because it was real enough of a risk. But usually I can't get enough of a risk to, I cannot get enough of a risk to sort of keep them in the clinic. There are many instances in the emergency departments where they have much more exaggerated forms of these challenges. Individuals apprehended downtown by first responders who are very intoxicated on methamphetamines. And this is a very challenging situation. I'm not gonna get into, I don't normally deliver care to folks that are this psychotic on methamphetamines, but how to best and most humanely care for those individuals so they don't harm themselves or anyone else. That is an active challenge. Usually in the clinic, I do a little safety assessment, and most of the time I can't get that they're actively a risk to anyone else, but it is true that they're not safe, that they could go get into a fight. But it's not sufficient for me to withhold them from leaving. I would, if someone, that's different from someone drunk on alcohol or benzos that's going to go get into a car. I will stop that. I will tell them, like, we will call 911 if you get into a car in the parking lot and drive, because we don't think you can drive. And so that would be one that I would intervene on. And if you call 911, they will respond pretty quickly to these instances. So, but that's been pretty rare. Usually if you let them know your obligation to call, to prevent them from driving, they'll sort of acquiesce and they'll be willing to sober up before they drive and get someone to drive them home. That's been my experience. So good question though.
I would agree. We've had individuals make very specific threats against a pharmacy or something like that. And in those cases, we have notified the police. If it's a very specific threat, and it seems like that's where their brain is at.
Yeah. And a lot of times, if it's a benzo user who's just impulsive, you can kind of talk them through how specific and sincere the threat is. But it's the stimulant, methamphetamine, cocaine users who really, I think I'm most worried about. Okay, thank you. Thanks, everyone.
Yeah, thank you, Dr. Reznikoff. Very pleasure to have you.
Yeah.
Yes, and thank you.
I appreciate the work you're all doing. Thanks.
Thank
Call
you.
anytime.